we have to move quickly towards the next session. It's already late. Please, I'll invite for the next session's chairmans, which is early post-operative management. Part 1, Dr. Y.K. Chawla, Professor, Academic Dean, KIMS Bhubaneswar. Dr. Anup Saraya, Professor and Head, Department of Gastroenterology at AIIMS, New Delhi. Dr. Balachandran Menon, Director of Liver Transplant and HPB Surgery at AIG, Hyderabad. And Dr. Dheeraj Agarwal, Senior Consultant at Pace Hospital, Hyderabad. And the first talk of the third session is immunosuppression strategies post ABO incompatible liver transplantation. I would like to call upon stage our speaker, Dr. Charles Panakkal, Senior Consultant at Gastroenterologist and Hepatologist at Aster Medicity, Kochi, Kerala. Sorry.
Thank you. Thank you. Thank you, chairpersons. And first of all, let me congratulate the Max team for organizing this excellent conference. Thank you for the kind invite, and it's always a pleasure to be here today. And liver transplant, we know it's an ideal option for HCC and end-stage liver disease, and its use is restricted due to the limited donor pool, especially in the East where there is a lack of disease donation. And breaking the ABO barrier in 1987 by Dr. Alexandre was an important milestone in transplant history. And ABO incompatible liver transplant accounts for around 10 to 20% of liver transplants in Southeast Asia nowadays. And in the rituximab era, the incidence of antibody-mediated rejection and diffuse intrahepatic biliary strictures have come to less than 10%. So this three meta-analysis that has come recently looking at comparing ABO incompatible live donor liver transplants with ABO compatible live donor liver transplants. And all the three concluded that in the rituximab era, in an elective setting, if you carefully choose your patients, you have a 3-year and 5-year survival, graft and recipient survival that is equal to a ABO compatible live donor liver transplant. And the game changer has been rituximab. And this multicentric study from Japan that showed that rituximab reduced the AMR from 23% to 6%, and there was no added increased risk of infections in their patients. So coming to immunosuppression protocols in ABO incompatible liver transplants, it can be divided into 3 stages. One is a pre-transplant immunomodulation and immunosuppression that has already been dealt with. Second is a post-transplant immunosuppression, and treatment of antibody-mediated rejection would be coming later in the day. So pre-transplant immunomodulation starts with the killing of the B cells to prevent production of the antibodies, and what we use is the rituximab. And whatever preformed antibodies that are there in the body is removed using one of the plasma therapies like therapeutic plasma exchange or double filtration plasmapheresis or immunoadsorption. And in our center, most centers, they use rituximab at minus 14 or minus 21 days. And in our center, we use 2 weeks prior to the transplant. And our target antibody would be around 1:16. And if it's more than 1:16, we use therapeutic plasma exchange to bring it down to 1:16, less than 1:16 prior to the transplant. And with improved desensitization protocols and we have been able to achieve a post-transplant immunosuppression that is almost similar to ABO compatible liver transplants. And what we use is a triple drug immunosuppression with tacrolimus, MMF, and steroids. So most of the studies in ABO incompatible liver transplants have come from Japan, and here they start TAC and MMF 7 days prior to the transplant. And their logic has been that TAC inhibits B cell proliferation and maturation, and MMF also inhibits B cell proliferation and inhibits plasma cells. So whatever B cell that escape the retux can be taken care of by the TAC and MMF. But we, like most centers in India, we start our post-transplant immunosuppression on the day of transplant. In route, we give around 10 milligram per kg body weight of methylprednisolone. And there are centers that use a higher dose of methylprednisolone as high as 50 milligram per kg of methylprednisolone in drop. And steroids are continued at a higher dose in the initial weeks, around 1.5 milligram per kg that started on post-op day 1, and they're kept high for initial 1 to 2 weeks, and then there's a slow taper. And unless patient has got a rejection or patient has got autoimmune etiology, the steroids are tapered and stopped over next 3 to 12 months, depending on center to center. And like most Indian centers, TAC start TAC only after the transplant, and the usual TAC level, target level would be around 10 nanogram per ml in the initial for 6 months. It will be varying anywhere between 8 to 12 in the first 6 months, and after 6 months we reduce it up to 5 to 7 nanogram per ml. And MMF, again, we don't start MMF pre-transplant. We start MMF only after the transplant, and dose ranges from 10 to 50 milligram per kg per day, and is titrated as tolerated by the patient. And I know that a few other centers in India, they start MMF like the Japanese. They start it 1 week before transplant, but we don't do it. So most of our patients at the time of discharge, that's around the third or fourth week after transplant, they'll be going home on a triple immunosuppression with steroids around 20 to 30 milligram per day, a TAC to maintain a level around 10 nanogram per ml, and MMF in the dose of around 1000 to 1500 milligram per day in 2 divided doses. The steroids are tapered in next 3 to 6 months unless the patient has a rejection or an autoimmune etiology. And initial TAC level for first 6 months in our unit would be around 10 nanogram per ml. It ranges from 8 to 12. And after 6 months, we go back to the usual dose around 5 to 7 nanogram per ml. And MMF, we use at a dose around 500 milligram BD to 1000 milligram BD, depending on the patient status. So coming to some of the special situations, first is HCC. The initial reports on HCC showed that there was a higher incidence in ABA incompatible, but now we have got 3 large studies that have come from from Korea that showed that ABA 3-year disease-free survival and 5-year disease-free survival as well as patient survival are similar with ABA incompatible and ABA compatible transplants in HCC, and this meta-analysis that showed the same. And the protocol, immunosuppression protocols in our unit are similar in patients with HCC. But to use everolimus, if you are a center that believes in everolimus prevents post-transplant immunosuppression, post-transplant recurrence of HCC, you can use everolimus. But I have heard Professor Gupta say that there's an increased instance of proteinuria in patients with ABA incompatible liver transplants. So if your center believes in the concept that everolimus can prevent post-transplant HCC recurrence, then you are free to use everolimus. And coming to the role of induction with basiliximab, as such, basiliximab induction has no role in ABA incompatible liver transplant. But many centers believe in using basiliximab for their ABA compatible liver transplants, and they continue to use basiliximab in patients in ABA incompatible liver transplants also. And if you want to reduce the dose of TAC, especially if renal dysfunction is a concern, then you might use ABA incompatible. You might use basiliximab in ABI, but I'm not sure whether you can totally delay TAC for 5 days as you do in ABA compatible liver transplants. And some of the studies that I'll come to later in DDLT settings and ALFs, DDLT setting especially in the West and ALFs in East, they use quadruple immunosuppression with basiliximab. So what about PBC, PSC, and AH? These are considered to be higher risk for AMRs and rejections in ABA incompatible liver transplants. But to use the same protocol as the Japanese, I don't have any experience in dealing with them, but then they might need a higher immunosuppression compared to patients with other etiologies like NASH or alcohol. What about in emergency settings like ALF and DDLT? Again, there's no standardized protocols. People are given, case series have shown that they have used rituximab immediately before when the transplant is planned or immediately after the transplant, after the reperfusion. And there might be added advantage of using immune absorption because when you use therapeutic plasma exchange immediately after rituximab, you might remove the rituximab from the circulation, whereas immune absorption may not do that. And there's one study from China that showed that they did immune absorption post ALF, post emergency transplant for ALF, and they did it on alternate days for the first 2 weeks, and irrespective of the titer, and they showed good results with that. And the studies from Taiwan that has been the abstract has been recently published with bortezomib given 3 days prior to ALF. And whenever you can't prime your patients with pre-transplant rituximab and immunoabsorption, then you might use IVIG splenectomy or basiliximab induction in such patients in the post-transplant setting. Coming to pediatrics, again, that's a unique population because of the immature immune system. And as already seen, they don't, infants less than 1 year don't don't mount API isoagglutinins. And pre-transplant immunomodulation, that varies depending on the age. We don't use immunomodulations if the titers are low in less than 2 years. And there are centers in India that don't use immunomodulation in patients less than 7 years. And post-transplant immunosuppression in our unit has been similar to ABI-compatible liver transplant with triple immunosuppression with cyclosporin, tacrolimus, and steroids. There's no difference between ABI-incompatible and ABI-compatible. So to summarize, pre-transplant immunomodulation, the advances in pre-transplant immunomodulation, especially the Retux, has been a game changer, and it has revolutionized ABI-incompatible liver transplants. And with these newer modalities of Retux and immunoadsorption, the survival of ABI-incompatible liver transplants has been similar to ABI-compatible liver transplants. And the immunosuppression post-transplant is almost similar in both ABI-incompatible and ABI-compatible, and varies from center to center. Thank you.
Thank you, Dr. Charles, for taking us through the immunosuppressions in ABO incompatible. You've saved our time, so let's have some questions. Sanjeev.
Thank you, sir.
Very lucidly. Now, if I have to really say what is the difference, I feel that the levels which we keep in ABO incompatible post transplant, the TAC level or the CNA levels, I think we tend to keep them a bit higher. Maybe it's our like sort of bend of mind, how we look at it. I would not cross 10 in a normal transplant LDLT, whereas in ABI, 10, 12 is something which 8, 10, 10, 12 is something which is not uncommon. Also steroids, which we would otherwise in LDLT would taper off pretty fast. In ABI, somehow we tend to have little higher steroid use in the first few days, maybe in a week or two. So what do you comment on that?
Yeah. See, again, the practice has been varying from center to center, and most centers in West would keep the TAC around, or again, East, they recommend keeping TAC around 10 to 15 nanogram in the initial 3 months. In India, again, I know the study paper from your centers recommended keeping it from 10 to 12, but most other centers, they keep it around 8 to 10. And including ours, we keep it around 8 to 10. We don't go above 10, even in ABI-incompatible liver transplants. And steroids, again, we have been using the same dose, 10 milligram per kg in the in raw period, but then post-op we tend to keep it a bit high for the initial 4 weeks. So tapering would be slow, as you said. And even in ABI compatible, we would stop by 3 months, but then ABI incompatible, we might we might slow the taper to 6 months to 12 months in ABI incompatible, unlike in ABI compatible where we invariably stop by 3 months, unless patient has got a rejection or autoimmune etiology.
I think that's what I would say. Agree with. Yeah.
Thanks.
Any other questions? Yeah. Charles, I want to know your protocol for rituximab. You said it's given 14 days prior in some centers, but you prefer. How many shots of rituximab needs to be given?
See, rituximab, one is timing. So timing varies between 3 weeks to 2 weeks before transplant. That's minus 21 to minus 14 days.
Right.
That varies from center to center. Our center, you said minus 14. And dose has been again varying. The standard recommended dose is 375 milligram per meter square. But I have heard high volume centers in India talk about using as low as 50 milligram per meter square in very sick patients. So the recommended dose would be around 375 milligram per meter square. And we do an average between the two. We use around 300 milligram per meter square. We don't go above 300 milligram in most of our patients.
How many shots do you
And it's a single shot. And just been shown that repeated use of rituximab increases the risk of infection without any added advantage.
Right. And with the use of rituximab, the biliary strictures, they are not as much as you were seeing initially.
Yeah, it was first used in 2003, and the study in 2014 by Egawa, they showed that there was a the AMRs reduced from 23% to less than 6%. Even the not much data on long term with diffuse intrahepatic biliary strictures, but still I would expect that it would be lower in this patient.
Yes, sir.
Hi, sir. I'm Dr. Venkatesh from Chennai.
Hi.
Sir, what would be the recommended duration till in the post-operative period that we have to check the titers, irrespective of the liver enzyme change? And my second question is there a role of rituximab in the post-operative period? Thank you.
Thank you. Yeah, you heard today morning Professor Gupta saying that they do it twice a day for the first week, and then once a day for second week, and then okay. What we do in our practice is that we do once a week for the first week, once a day for first week, then alternate days for second week, and then twice a week for 4 weeks. Normally, after 4 weeks, I don't think the levels of the titer levels have any value. So that's what we do in our unit, and that's what most centers would do.
Sir, would you do the plasma exchange in the post-operative period for the titers less than, say, 1:64 or whatever, or irrespective of the liver enzyme? I mean, we are not suspecting any rejection or anything. What would be the titer in which
No,
you could go ahead?
Yeah, if the titer doubles from 1:16, the titer doubles in the post-operative period, we would invariably do a plasma exchange. We don't wait for AMR or enzymes to go up or liver necrosis to happen. That's our practice. But yeah, so if the titers go up double, or if you have got a rising titers with bilirubin, elevation bilirubin, or rising, or you don't have a rising titer, but you have the abnormal LFTs and you suspect that you are dealing with AMR, then we would definitely do a plasma exchange.
One practical problem faced is patients with recent AKI, pre-op recent AKI, or say creatinine borderline 1.5, 1.6, proteinuria. So what changes would you make in pre and post-op management?
Yeah, okay.
It's a difficult question for ABO compatible as well. But
I
here,
know.
what would you?
Yeah, we would use basiliximab in such patients. I don't think we are not. First of all, renal failures. We have not taken patients with renal failure in our unit for ABO incompatible liver transplants, because we consider them to be high risk for infections post transplant also. But other centers can answer on that. And what we would do if you take up a patient, we would use basiliximab. I don't think we will delay the TAC till 5 days. We will definitely use a lower dose of TAC. Dr. Saigal, you want to answer on that?
No, I think what Charles is telling is right, because renal failure and ABI is really a very bad combination, and electively, as far as possible, I would like to avoid. But I think as we do more and more cases, we know these sicker patients, they have renal dysfunction as part and parcel of the problem. So probably we'll have to deal with question which Bala has raised, and some better strategies need to be there.
Actually, because they are on high dose steroids, you probably don't need very high TAC levels.
Yeah,
So
yeah.
if
I
you
would
give
do.
basiliximab, it's basically taken care of.
Yeah. Just one thing I'll add here. We have actually done a Google questionnaire survey where a lot of these questions have been asked, and we have, I think, 25 responses till now. So I was planning to actually summarize and present here, but I think we're not doing this in this meeting. So whoever is there and has still not done, you're most welcome to add your points of your opinion. Actually, it's an independent opinion, and we are then we already compiled these 25, but we can add on to it, and maybe end of the day we'll have more knowledge.
Yeah.
And these are very important questions, and a lot of these questions we don't have answers, to be honest. So I think a survey of this would probably make us wiser.
Can I ask the audience just one thing in relation to this? Would you delay the TAC for 5 days, or would you use a lower TAC if you are using basiliximab?
See, number one, basiliximab, I mean, we are not using like as a protocol in our patients. Very infrequently use. In ABI also, we're not. I know kidney people are using. I have spoken to nephrologists, but we are not using. And secondly, in ABI, not giving TAC for 2, 3, 4 days would be
That would be
something psychologically will be very uncomfortable.
true.
I have a question.
Yes, sir.
So does the ABO incompatible transplant have have higher incidence of T-cell mediated rejection also, or is it only MR that we are worried about?
No, ABO incompatible has got a higher incidence of ACROs and
That is the
TCMR.
reason why we are keeping a higher level of TAC. compared to routine transplant.
Yeah, and I should know, as I showed in one of the slides, TAC also deals with B cells also. It inhibits B cell proliferation and maturation. And MMF also inhibits B cell proliferation and maturation. So that prevents a rebound of antibodies. So you need to keep a higher TAC for both these reasons.
Thank you.
Sir, what is your protocol for steroid taper immediately after transplant?
Okay. What we do in our unit is that we give 10 milligram per kg in raw, then 1 milligram in the initial first 1 milligram per kg initial first 2 weeks. By the end of 2 weeks, there will be an oral steroid around 40 milligram and then gradual taper. But at discharge, there will be around 30 and taper it off by around 6 months to 12 months. So unless patient has got a rejection or etiology is autoimmune, we tend to. I know there are centers that stop in 3 months, but we are not comfortable stopping steroids that early. So we tend to delay the taper and stop to around 6 months to 12 months.
Next. Yeah. Thanks, Charles.
Thank you, sir.
Sanjeev, just how many ABOs incompatibles have you people done here?
We have done 95 plus actually as of now. Dr. Gupta presented data of 91 patients.
Okay.
And I think we are nearing 900 actually. Shweta is sitting here. So we've done 3 more as we speak.
Very good.
So we're probably going to be, not that we should be aiming that, but probably we're going to be doing about 100 by end of, in a month or so.
Right. Thank you.
Thank you, Dr. Charles, for concise talk and detailed discussion. Now, moving forward to the next lecture is antibiotic and antifungal strategies in ABO incompatible liver transplant. So, I'll invite Dr. Dinesh Jyotimani, Director of Hepatology at Dr. Rela Institute of Medical Center, Chennai.
Good afternoon, everyone. And first of all, I would like to thank Dr. Sanjeev Sehgal and Dr. Subhash Gupta for the opportunity. If Charles' talk was difficult, my talk was even difficult, I would say. Antibiotic and antifungal strategies in ABO incompatible transplantation. So when I searched the literature, there is hardly any evidence for all this. So then I realized this is a very niche topic. Everything, the ABO incompatible itself is a niche topic. And then in that, if you're looking for antibiotics and antifungal strategies, it's going to be hardly any evidence in the literature. But let's ask ourselves certain other questions. How we deal with the infections and use of antimicrobials in these patients. I'd say most of the slides, you'll see a lot of overlap in today's talks, actually. So this is a standard desensitization protocol for ABO incompatible transplantation. There will be a lot of minor variations depending on the center. Say, for example, you may have heard rituximab, some center gives 7 days and some center gives sort of 3 weeks. And also many centers do plasma exchange, and some centers we use MMF. So a lot of variations will be there, but overall this is a strategy. And previously many centers used to do splenectomy, but that's been stopped a while ago. So when it comes to desensitization protocol, there are no guidelines. First of all, that's the first point. And then, can you avoid rituximab? Because rituximab is associated with infection. The studies shows that in the absence of rituximab, your ABO incompatible survival is only 20 to 30%, whereas with rituximab, it's as normal as ABO compatible transplantation. So therefore, you cannot avoid rituximab here. Okay. So next question is rituximab associated with increased risk of infection? Answer is yes. So there is 1 in 5 patients can get infection with rituximab over a median period of 2 months. But this is this data is from a chronic kidney disease, glomerular disease. This is not in transplant patients. Okay, so that we have to understand. So the question is the next question, the same answer. Is rituximab associated with infection? Then what are the risk factors? So if you are diabetic, if you have chronic kidney disease, if you have low immunoglobulin hypogammaglobulinemia, then you are prone for sepsis with rituximab. And also looking at the studies, the median dose they received was over 3 grams, actually 3,100 milligrams. we hardly use such dose in liver transplant patients. So usually we stick to very much on the lower side, less than 400, 500, even lesser than that these days. Now, this is in non-liver patients. Next question is rituximab associated with increased risk of infection in ABO incompatible liver transplant patient? Again, this meta-analysis was shown earlier, but for a different slide. So if you look at it, the overall infection rates are not very similar. It's a comparative analysis between ABO incompatible and ABO compatible. And it is not any different to the compatible transplantation. The p-value is not very significant. The other question is rituximab associated with bacterial infection in these patients? Once again, there is no difference between ABO compatible and incompatible group. So it is more or less clear that the rituximab dose what we use is not associated with any overt or extra sort of risk of infection compared to the higher doses that's been used in other diseases. Now, where then rituximab associated with infection is when you have a genetic polymorphism. It is called the FC receptors polymorphism, where your histidine is replaced by arginine is replaced by histidine. That increases the risk of infection when used with rituximab, and this is it potentiates the action of rituximab by the receptors. So this is something in clinical, not in clinical use, but something we can discuss about. The next question is MMF associated with infection? This study is from renal transplant recipient. Yes, definitely is associated with increased risk of infection. It's around over 50%, and it was very significant. In renal transplant recipients, MMF introduced more than a year later after the transplant as a replacement for azathioprine. Still, there was high risk of infection, over 66%, and it was predominantly bacterial with pneumonia or UTI. Now, what about in liver patients? Is MMF associated with infection in liver transplant recipients? If you look at this table, infection is on the leading side. Around over 25% of patients can get infection because of MMF. Now, we all use MMF in most of the patients following liver transplantation. So once again, we go to the meta-analysis and the systematic review. If you look at it, the overall picture, when we use it with tacrolimus, obviously we are not going to use high dose MMF. We're going to use sort of little on the lower side. So the doses used for liver transplant recipients is not associated with any extra risk of infection per se. So once again, it was not significant. And during the search, I found out very interestingly that MMF also protects infection actually. So in mouse models, it's been found out low dose mycophenolate actually reduces the chance of SIRS and improves bacterial clearance and phagocytic function. So this is a very interesting point here. So we now have evidence of rituximab doesn't cause extra infections, and as well as the MMF that we use in the pre-op period may not cause additional risk of infection. Now the next question is ABO incompatible transplant a risk factor for sepsis? Is the surgery itself is a risk factor for sepsis? Again, if you look at this analysis from Takeda, most of the studies are from Korea and Japan. Yes, ABO incompatible, again, small numbers, but yeah, it was associated with increased risk of sepsis with a hazard ratio of 8. But what they found is it was associated with sepsis, but not septic shock or mortality. Most of these patients recovered without major complications. Is infection more common in ABO incompatible transplantation? So other question actually. If you look at the comparative analysis, this is the largest single center experience from ASAN. So if you look at overall, the septic complications remain very similar, 10.2 versus 10.6 as to ABO incompatible versus compatible. So overall, we are seeing that the infection rates are not very high as what we usually think in this group of patients. However, we have to be careful. So what are the strategies to reduce infection in ABO incompatible transplantation? Now, we've been going on this discussion in the previous two talks actually. So what is a titer? Is there a titer you can avoid giving other sort of desensitization protocol? Can we just get away with rituximab only? So in this study, they looked at if a titer in titers less than 1 in 32, they used only rituximab, and titers more than 1 in 32, they used rituximab with plasma exchange. So if you see the initial CD19, CD20 count and the baseline and the pre-liver transplant 1 week after the transplantation, there is actually no statistical difference between both the groups. So it is okay to say, although these are very smaller studies, it is okay to say maybe you can get away with rituximab alone if the titers are very low. Now, there's another modification to this. There are 3 eras were compared in this study, actually. So if you look at previously, they used to use a lot of splenectomy for controlling, because in the absence of rituximab. And then came rituximab plus high-dose rituximab plus plasma exchange. And then the third era, the recent one, is fixed dose rituximab, which is 200 milligrams, plus plasma exchange, plus antibiotics. So antibiotics they used was Bactrim for 3 months in the post-transplant period, mainly against pneumocystis and nocardia. So if you see this sepsis rates, the sepsis rates have fallen down significantly with low-dose rituximab, with plasma exchange and use of antibiotics. So these are the modifications of the strategies we can be adopted to reduce the chances of infection. So these are predominantly bacterial infection. Is rituximab a risk factor for fungal infection? You've seen this slide earlier. So what they've done is, so this is a low-dose rituximab, and low-dose rituximab given twice, and standard dose rituximab and given twice or thrice like that according to the protocol. And these are mostly retrospective studies actually. So if you look at the fungal infection, when you use low dose single, there's no fungal infection. But as and when you go across to the other side with a regular dose and given more frequently, there is a very significant increase of fungal infection in this group. So therefore, there is dose-dependent increase of fungal infection in rituximab group. And what about liver transplant patients? Once again, it comes back, we use lower dose. We don't use more than 1 dose. And when they looked at the meta-analysis, there is no increased risk of fungal sepsis in patients who are treated with rituximab in the pre-transplant period. Now, let's go to the actual question. So I searched the literature. What are the antibiotics given in these patients? So most centers use cefotaxime, and centers used ampicillin sulbactam. One thing common is Bactrim has been used by most centers, and the duration varied from 2 weeks to 12 months in the postoperative period when it comes to antibacterial drugs. And fluconazole has been universal in most of these patients, and the dose varied from 100 to 400 milligrams. And they claim it's a very excellent antifungal drug in these patients, actually. And very occasionally, patients do undergo splenectomy, and these patients should be provided pneumococcal vaccine to reduce the chance of pneumococcal sepsis. I looked at the ESOT guidelines for organ transplantation, the European Liver Transplant Society guidelines. Once again, they haven't mentioned anything about antibiotics in ABO incompatible group. So it says that we are not going to have a special antibiotic coverage for these patients, but whatever we use, we have to be a little sensible. So what are the protocols? There are 3 centers. We managed to get some protocols from the LDLT centers. So again, if you look at the rituximab dosages are slightly different, but again, more or less we use slightly lower dose, but we also use mycophenolate. And antibiotics, piperacillin tazobactam, what we use, but I'm sure many centers use similar drugs. Antifungal fluconazole we use, very standard. So last couple of slides. So why antibiotics important in this group of patients? ABO incompatible transplant is a relatively high risk surgery, and it's a balance between immune function and the risk of infection, because there's a lot been spoke about AMR, and it all depends what the baseline isoagglutinin titer is, ABO titer is. So if the titer is very high, you're going to use more and more drugs, and therefore the risk of infection is a little bit on the higher side, and the desensitization protocol will vary accordingly. So if I summarize saying, we're going to see two group of patients for ABO incompatible transplantation. This is pretty much hypothetical actually. So you're going to see somebody with low ABO titers, low CD19 count, where we may end up using rituximab alone. And these patients may not need a longer course or a higher spectrum antibiotics or antifungal cover. Whereas those with higher titers, higher CD19, CD20 levels count with higher dose of rituximab, MMF, plasma exchange, and eventually getting higher immunosuppression in the post-transplant period. So they may require special attention, and your antibiotic coverage have to be modified along with antifungal cover accordingly. Thank you.
Thank you, Dinesh, for excellent presentation. I think you have addressed all important issues, and now house is open for discussion.
Yeah, I think Dinesh, this was very masterly talk, and you're asking me like, what would you speak? I think you have really, analyzed and discussed very well. In my experience, the second group in your last slide is what we face. Patients have titers which are high, they have undergone various procedures, plasma exchanges, and rituximab. So invariably, if you ask me, like we are more or less, pushed to using higher antibiotics. And even antifungals also, many times I realize, if you ask me how many people have you been given, this, and one of the higher antifungals, antifungal and so on, in ABI versus non-ABI, if I do an analysis, I'm sure the ABI-LT have a much higher incidence of higher antifungals.
Same, I agree with that actually. The predominant patients are the group 2 patients we'll be seeing actually.
So these ABI patients, they are more prone to develop candida. So do you think fluconazole is enough, or you want to give some echinocandins to cover for certain period of time initially?
Actually, it's literature does suggest that they are prone for candidal infections. Most of the Western and the Eastern literature, they strongly support the use of fluconazole. But as Dr. Sanjeev Sehgal said, like it's more to get a complete coverage, we probably use a little bit on the higher side, earlier maybe a micafungin or echinocandins group of drugs in the initial phase, and then taper down to fluconazole when they get out of ICU. Yeah, this is probably the.
And similarly for CMV prophylaxis, they should cover for CMV infections.
I didn't specifically cover that.
So thanks, Dr. Charles and Dr. Dinesh, for the excellent presentation. I think we'll go on to the next session.
I want to ask one question. So Dinesh, excellent talk. So now we are moving towards ABO incompatible. First it was living donor versus DDLT, and now it is living donor liver transplant and ABO incompatible and in sicker patients. So these patients, even the second category as well as the sicker patients, they are very prone to having need for antifungal cover. Correct. Because they are very prone to having fungal infections.
Correct.
So would you like to, in your practice, how would you have a sick patient admitted in ICU, your ACLF category?
Sick patients admitted ICU, question is, should we even consider for ABO incompatible? That's the first question we asked actually. So obviously if you have no choice and get away with that, obviously we give rituximab and plasma exchange and take them for transplantation. But obviously in the post-op period, they will have a delayed recovery, and you have to have a broad spectrum antibiotic and antifungal cover.
Which antifungals would
Yeah,
you go for?
we use micafungin actually. So micafungin is what we
Because
commonly
as a practice,
use. That is a practice.
That is
Yeah,
what
that's
we do.
yeah. So if you ask me evidence, but again, so we don't have sort of written evidence. But yeah, that's the most common practice across.
Sir, during the preparatory phase for ABO incompatible LDLT, during that time, what antibiotic you will be giving preemptively, like 2 to 3 weeks before?
See, if you give rituximab, actually you don't have to give antibiotics with that, because one, it doesn't act immediately, and then by the time you discharge these patients, but there's no evidence actually what antibiotic to use. Thank you.
Thank you, sir, for the excellent talk, and thank you, chairpersons, for chairing the session.